Hi, everybody. It's Dr. Eric Balcavage and Dr. Erica Riggleman with the Thyroid Answers Podcast. How you doing, Dr. Erica? How are you?
Great.
Fantastic. You guys getting blasted by the storm?
It's just kind of a wet mess out there. It's not really freezing, thank goodness.
We have a special guest on today, Dr. Tara Scott. She's a medical doctor from Ohio area, and I'm sure that she is getting some foul weather. Are you not?
We are very icy and a lot of rain right now, but we got pounded with snow. We had snow on Sunday.
So it's really all her fault that we have the bad weather here on the East Coast because she allowed it to come this way. She should have fixed that as an integrative medical doctor, but we won't blame her for everything. But Dr. Scott, thank you so much for coming on the Thyroid Answers Podcast. We appreciate you coming on, and we know you've got a ton of information that you can provide our listeners. But can you do me a favor? Can you give us a little bit of background about you, a medical doctor, dipping their toes and actually maybe jumping into the pond of integrative and functional medicine? How did you get from traditional allopathic medicine to integrative and functional medicine?
So I would say I'm all the way in. I'm on the dark side where I am, So yeah, I was very traditionally trained, and my background is OBGYN. I did a lot of deliveries, a lot of surgeries, and everybody has a story as to how they end up where they are, right? It was really two things for me. One is my own personal issue with women's hormones, infertility, Hashimoto's thyroiditis myself. So just kind of learning about what's affecting me. But the biggest thing that really affected me into an integrative and functional approach was 11 years ago, my brother suddenly passed away. He was 38 years old, but he was a diabetic. He was on a statin. He was a smoker. He had high cholesterol. He had every risk factor. But to traditional medicine, he was healthy. So when that happened, obviously, other than the shock, of having your family member die, I started looking into everything and seeing all these warning signs. And I just felt like, there has to be a better way to do things. So the first thing that I kind of did was obviously learn about hormones, because that's where most of my practice was. But then I went on to get board certified by A4M in functional medicine. I further went on to get a second board certification in integrative medicine, and now I'm doing some IFM courses. So I kept my OB certification. So I have 3 board certifications. My practice is mostly women's health, thyroid, adrenals, so we do a lot of that. So, and I have, special interest in things like breast cancer, which is hormonally driven. And so in my area, I was kind of the first person to do this, but because, Akron, I don't know how big Akron is. It's not a small town. We've got 2 teaching hospitals in here. So, but maintaining my contacts and having a good reputation in my town, allowed me to kind of navigate back between the allopathic and the dark side, as we mentioned. My old OBGYN partner is now the chairman of our local hospital. It's a 7-hospital system. So it's a large, and a training hospital, teaching hospital. And they knew my reputation was good and that what I was doing was evidence-based. And so I'm now the medical director of integrative medicine at Summa Health. So I took that over about a year and a half ago. They hired me to try to start something. So I'm fortunate, just being, like I said, that I've been in practice over 22 years. And so they know me. But it's been difficult to navigate, the dark side here in a very traditional setting.
So, we kind of talk about the dark side or whatever, but the reality is there is a benefit to acute care allopathic medicine. I think you would agree with that. I agree with that. Dr. Erica agrees with that. I think where we fail, and I think it's the thing that you're talking about, maybe that failed your brother, is that there's a difference between healthy and managed illness, right? And the allopathic model is great at the acute care model, and they're good at managing illness, but it's really not a healthcare model.
Right.
And I think that's where the problem is. And when we take those acute care ideas to try and save people in crisis care and apply them to health, it just doesn't work. Really all we're doing is managing disease. Would you agree with that?
Yeah, I think, if you're not sick, you're considered healthy. And exactly, he wasn't necessarily sick, but he had every risk factor. A million red flags. So now most of my practice is really with wellness, people who want to be preventative, and that's what I talk about, and that's my message in town. But, even just with what you're doing with thyroid, you probably see a lot of people that come that they're not feeling optimal, and their doctors told them that they're fine because their TSH is fine. So that's a huge area that we see the way traditional medicine is doing it. And the endocrinologists in town probably aren't fans of mine. So, they're very traditional. So.
Yeah, I think it's, whether it's symptoms related to thyroid, being fatigued and tired, or if you're having other symptoms that are, pointing you in the direction of some sort of disease, we often, in our traditional medical system, we just try to prescribe a medication to suppress the symptoms instead of asking the question of what's causing the symptom and trying to get to that root cause. And I think that it's wonderful that you've made that tradition and that you were able to step outside the box and actually look at the body as a whole, because a lot of practitioners have a hard time making that transition. I'm sure that what you went through was really eye-opening and opened that door for you to be able to see this whole side of medicine.
Sure. Not to mention, people don't have the time to go back and learn. I mean, to teach yourself this, right? It's not taught in school. And so you have to teach yourself not only nutrition and everything else. I mean, what it's cost me to re-educate myself is more than I paid for medical school, so if you're not passionate about it, why would you, as far as a traditional doctor, you're asking like, why are not open to it? Because people just get in, they are in their comfort zone, and unless they have a passion or a personal experience that has showed them another way, they're not going to be motivated to go back and learn and go back in courses and pursue this path, because it's expensive, it's time consuming, and I would be making more money if I was delivering babies, so honestly, it's not, you have to have a personal passion about it. So that's it, and we're not taught it. So the traditional doctors, I think for most of them want patients to be well. They're just overwhelmed with the amount of patients they have to see. They want to stay in the bounds of what's their college is teaching them, and they want to be compliant. So it's a difficult thing to navigate.
Right. And so they've got an insurance company that they're beholden to some degree. They've got peer what the standard of care is, that, and if you go outside that standard of care, there's a potential to have some repercussions from that. So it's funny. I think one of the early functional medicine seminars I went to, I was sitting next to a medical doctor, and he was like, "You got to be kidding me. You guys have to pay for this?" He's, "I can't believe you have to pay." He said, "We usually when I go to a seminar, it's paid for. There's good food, all this stuff. Everything's taken care of." And I'm like, no. You're out. There's no money in these seminars. So it's out of pocket expense. He's like, "Oh my gosh, no wonder nobody does this stuff." So it was a lasting impression for me. Like, oh, a lot of their continuing education was covered. Oh, we never had that. But let me get to one of the big questions that I know a lot of patients struggling with chronic thyroid problems have when they come to a functional medicine or integrative medical person. They're struggling with chronic thyroid problems, and we look at their labs and we say, "Hey, we need to run a more comprehensive lab panel." They'll say, "My doctor already ran a comprehensive thyroid panel," and you see it, and it's TSH, maybe T4 or free T4. And when we explain to them that it's not a comprehensive panel, they're like, "Well, why doesn't my doctor run a comprehensive panel if there was value in it?" And I usually have my explanation, but I'd love to hear you tell our listeners why traditional allopathic medicine just really runs TSH maybe as a screening test, and maybe T4, and rarely ever any of the other markers.
I mean, you hit it on the head. They are answering to insurance companies. So the studies are done on TSH, and that's how they're treated. They're taught. So they're not going to order something and then the patient's going to complain about it not being covered, So that's the things that we deal with, dealing with insurance. Then if we do decide to order something, then the patient's calling us and complaining, "I got this bill from the lab," then all that. So basically, a lot of their literature and is if you actually look at their textbook, Harrison's, internal medicine, I teach a course to naturopathic physicians, whatever, we wrote in 2010, and we talk about menopause, perimenopause, thyroid. So a lot of the data we got straight from Harrison's Principles of Internal Medicine. So it's in their texts about the relationship between reverse T3, free T3, total T3, total T4, but you're taught it and you kind of forget it then, right? So what you're taught in residency and fellowship is TSH.
Is it fair to say that really the focus on TSH is really based on treatment, right? So if the goal within that allopathic model is to restore TSH to lab value and T4 to lab value, that's really the only thing you need to really prescribe T4. And so if that's the model that you're trying to do, is trying to normalize TSH and T4, it's really not important to understand what T3 or reverse T3 is. Is that safe to say?
Part of it, and I don't want to make a generalization, because there is like one endocrinologist in town that does listen to patients, but a lot of the endocrinologists are inundated with diabetes, sick patients. So if you have a patient that has thyroid that's like, my hair is falling out, but I'm still getting through my day, I'm still functioning, I'm not feeling great, and their TSH is 3.75, oh, it's within the normal limits, why dig deeper, right? They're not looking at an optimal range. They're looking what the lab says. They're not looking at quartiles. So that's just part of it, is that they're not really sick compared to who they're seeing, like the diabetics with foot ulcers and, the really sick people.
Yeah, so I think there's that. I say that hypothyroidism is a spectrum issue, right? It's not what we diagnose as primary hypothyroidism is really the end stage, not the beginning of hypothyroidism. Just like diabetes is not the beginning of a blood sugar problem, it's the end stage of it. So, and that part I get, but really, if you're prescribing thyroid hormone, normalizing TSH and T4 is what you need. There's less concern about what reverse T3 is, because as the standard is to restore those two values.
But
so
they're not even really concerned. Like, one of the things I'm sure you guys see all the time is a low normal T4 and a low normal TSH. They're not even concerned. Well, that should be inversely proportional. That
right. So the
middle of the range, so you're good, and that's
right.
Discussion goes.
Because they're using the disease range, right? We're in functional and integrative medicine. We're saying, hey, we should be as close to the median, not on the outer edges in the D range or the F range. We're concerned about getting them optimized. And so that's a huge difference, is the lab values that are used. And, it is, I think the other thing that we have to take into consideration, and I'm sure in your teaching, you kind of teach part of that, is sometimes lab values are normal but inappropriate, right? Sometimes values are abnormal but appropriate given the given situation, and it's our job as the doctors or as the physicians to determine, hey, that is the normal value, but given all the things you're complaining about and the challenges you're having, it's inappropriate, and we need to understand why. And TSH is a great model for that, especially when we start talking about cortisol and the impact that inflammation can have on TSH. So that part's good. And I think the next thing we want to kind of talk about is when you look at thyroid physiology now versus maybe previously, what tests do you really like to run when you're looking at a thyroid panel?
So the majority of my patients are women. So a lot of times, because the total T4 and T3 are affected by estrogen, I don't usually order those. Sometimes if the lab they're going to has that on the panel, I might have it, but I'm more interested in free hormone in my practice, because estrogen can skew that. So free T3, free T4, I order thyroid antibodies, TPO, thyroid globulin, I order reverse T3, and obviously TSH.
So pretty close to what we would say a comprehensive panel, right? Which is different than what most people are getting done, TSH, maybe T4. Taking a look at the free hormones, you may or may not take a look at the total hormone load, taking a look at the binding globulin aspect, and definitely looking at reverse T3, what we call the deactivated form of thyroid hormone. Awesome, good.
So when you just mentioned that the sex hormone, specifically estrogen, plays a big impact on thyroid physiology and the thyroid hormones. Can you explain a little bit how estrogen impacts maybe like you said, the free form, and how it affects the whole physiology, and why somebody would produce symptoms if they have some estrogen issues?
Yeah, so it's pretty common over 40 for your progesterone to drop.
Mm-hmm.
And then, of course, life and stress and cortisol contributes to that. So if your estrogen is out of relationship to progesterone, out of balance, then you're at what we call estrogen dominance. High estrogen, either relative or absolute, will affect the binding protein. Now, certainly if you're taking estrogen in the form of an oral contraceptive or oral estrogen, which a lot of traditional doctors will prescribe, that's going to increase your binding proteins, sex hormone binding globulin, cortisol binding, thyroid binding globulin. Anything that increases the binding protein is going to affect less free. So we see that a lot. And so again, if the practitioners in town will order a thyroid hormone, it's usually in the form of a total T4. They don't usually do 3, because it's like a reflex panel, this TSH reflex total T4. So it's not a free T4 normally. And so any abnormality or any estrogen dominant state can affect the binding globulin. Now we've studied this in detail in pregnancy, which is why it's like mind-boggling. We are taught in pregnancy that you need the free hormone, that you can't rely on TSH because of the estrogen in pregnancy. But then once someone's not pregnant, we don't think the physiology is the same, in perimenopause and menopause. I mean, it doesn't translate, which is why it's interesting.
So there's also some correlation with how estrogen impacts sodium iodine transporter, correct?
Well,
Do you see problems there?
You probably are a little bit more up on that than I am as far as that cellular level.
Okay. So yeah, there's definitely an impact that estrogen can have on the uptake of iodine into the thyroid gland. So that can have an impact. And then we definitely see that estrogen has a huge impact on bile physiology, right? Compromising bile physiology. And it can do it from a number of ways. One, it can block that sphincter of Oddi, right? And so now we can't get bile flow into the intestine. It can also cause some challenges with the MRP2 and those detoxification pathways out of the liver to get things into bile. So that can have a major impact. And then we can have the backup of bile flow into the bloodstream, and we get too much bile acids in the blood flow. That's where sometimes our hypothyroid patients can really have some hyperthyroid symptoms occasionally if we get the backup of bile flow, because those bile acids will activate the TGR5 receptors on some of the tissues and increase that deiodinase 2 activity. And so you see people sometimes who are tired and fatigued, and then they're saying, but sometimes I'm getting these flushes of hyperthyroid symptoms, and that can be a huge reason why. So tying in with the estrogen piece, then there's a lot of women being put on hormones, right? Bioidentical hormones and other hormones. And do you see a major problem for a lot of women as they're put on these hormones, how it impacts their thyroid physiology and symptomatology?
So I see, traditionally still what's standard of care is if someone comes in their 40s and they have a regular period is to put them on an oral contraceptive, which is not bioidentical hormones, it's synthetic. That's the more common situation. We don't use oral estrogen. We use transdermal, which is not supposed to have the effect on those binding proteins as the oral does, because it doesn't have first pass metabolism. I do have patients that we screen their thyroid, and I see that they have lower levels of free T3 and free T4. And once we fix estrogen dominance, those levels go up without treating the thyroid at all. So that's a common situation as well. Putting people on, if you're talking about the traditional world, they're still using oral estrogen and synthetic progestins, and that can affect the thyroid function as well.
Absolutely. Okay, great. So, and then the symptoms that somebody might see of estrogen dominance, there's a crossover and similarity to those that we see with people with hypothyroidism, right?
Absolutely. I see it all the time. They're like, my thyroid has to be abnormal. And I think it's that link with the binding protein. As I mentioned, like some of the patients, if we restore their estrogen dominance and balance their hormones, either through supporting estrogen detoxification or giving them progesterone, depending on what the cause is, then a lot of times that will fix their thyroid function, if that seems to be the cause. So
I think, just like with thyroid, we want to run a full panel, and there's lots of different schools of thought on how to assess thyroid function. So what do you prefer? How do you assess somebody's hormones when a patient comes into you that you're suspecting hormone issues?
That's a great question, and there is no standard of care, and there's not even really agreement on how to test. So I will tell you that personally, I do all 4 types of testing. I do serum testing, I do saliva testing, I do dried urine, and I do blood spot testing. And this is one of the things that we teach in our course, is that there's no end-all be-all for testing. It really depends on the clinical situation. So if I want to know what the ovaries are producing, if someone is still cycling, I'm going to start with serum, and especially because then I can grab the thyroid panel at the same time. If I want to know what their estrogen load is in their aromatization, because we know that estrogen can aromatize to estrone, testosterone can aromatize to estrone. That happens in the peripheral tissues. You're not always going to catch that in the serum, in the venous serum. So I feel that saliva is the best measure of tissue load. Now, urine gives you metabolites. So that tells me how's your methylation working? How is your metabolism working? But remember, the kidney is encapsulated. The only thing coming through the urine is going to be via serum. So anything that's in the serum is going to go to the kidney, and you're going to get conjugates in the urine. So that's great for metabolism. Blood spot, pricking your finger, is capillary. So that's whole blood, it's capillary. You're going to get free hormone there. So those are the 4 different types of testing that we do, and it really depends on what I'm trying to find out.
So what would make, is there let's say it's your menopausal female who's struggling, what would be the preferred test in that situation?
So if I'm 100% sure the person is menopausal, I mean, the benefit of the serum testing is you get the FSH, right? So you can tell. Because in this situation, we see a lot of women who have no uterus and still have ovaries, who have had an endometrial ablation and still have ovaries. So you can't go by 1 year without a period. You have to see what the endocrine function is by doing the FSH. So if you have someone, let's just say, that has a hysterectomy, there's going to be no benefit in doing serum testing, because their hormones are coming via aromatization from DHEA. So the sole source of hormones after menopause is DHEA. So that's peripheral conversion. And if you look at the studies on endocrinology by Dr. Labray, who did all the data on DHEA before taking that to the market, DHEA is involved. I'm not sure if you're familiar with endocrinology. So basically, DHEA is a prohormone. It gets into the cell. Depending on the enzyme that is in the cell, it's either converted to estrone or testosterone. It has its action within the cell, and then it's conjugated, it's deactivated and excreted as a metabolite. So this is happening in the cell, and you're not going to catch that conversion in blood testing. So with a person who's menopausal, let's just say they're after a hysterectomy, depending on what I want to see, I might start with urine or saliva.
Okay, awesome. So I guess we could tie into that. So estrogen's got a role, and when you're looking at, we typically look at thyroid physiology not as the primary problem, but as kind of the effect of some type of stress response: physical, chemical, emotional, microbial, poor membrane health. Something that when there's a stress response, we want to slow metabolism down many times. And so we see that kind of chronic hypothyroid symptoms. So if you have somebody who's coming in with thyroid symptomatology, even their labs may look off, you see the hormone issue, your primary thing would not necessarily be to rush to support the thyroid tissue specifically and try and restore TSH or lower antibodies, but would it be more in line to deal with that underlying stressor, like what's triggering the hormone imbalance or the estrogen imbalance?
Yeah, I mean, we always do try to treat the cause and look for the cause. And a lot of times it's gut, like you said, infections. So a lot of times, especially with Hashimoto's, we're telling them to make dietary changes, cut off the gluten out of their diet, find out where the inflammation is, do stool testing to identify problems with the gut as far as autoimmune thyroid. And I would treat probably the menopause. So it's a little bit different as far as menopause versus thyroid, because there is a time when the ovaries stop working. And some people are symptomatic and some people aren't. And the studies are pretty clear as far as bone health and heart health. The number 1 killer in women is heart disease. Number 2 is stroke. Number 3 is breast cancer. Number 4 is lung cancer. If you add up 2, 3, and 4, you don't equal the number of deaths from cardiovascular deaths. And so estrogen is providing that protection on early start. Now, that doesn't say that everybody needs hormone therapy. Some people's adrenals are fully functioning and their DHEA is good, so they're able to make hormone after menopause. But women who've had their ovaries out or have had lots of stress and poor borderline functioning adrenals, a lot of times will benefit from hormone therapy. So we check all that out. We talk to women about, obviously lifestyle, sleep, stress reduction, dietary changes, and some women still choose and need hormone therapy. So just being a gynecologist, that's going to be a lot of our focus. We don't jump in and treat the thyroid right away. I mean, if someone has thyroid antibodies, a lot of times we'll use some kind of supplements for inflammation to try to, selenium, you got your micronutrients and try to balance that. So we'll use that. But I do write thyroid hormone replacement when needed.
So as it relates to thyroid hormone replacement, do you have a particular form of it? I know there's a lot of, some people are all for Armour, some people like the levothyroxine and Synthroid. Do you have a personal preference when you're having to make that recommendation to patients?
When you're talking about commercially available thyroid replacement, it is bioidentical. It is T4, but it's got excipients in it. It's got gluten and it's got dairy in it. So a lot of our patients, we're telling not to use gluten. There's only one commercially available form that doesn't have dyes or fillers. Then you got to talk about that conversion from T4 to T3, which isn't included if you're just replacing with levothyroxine. So sometimes people will add the T3 replacement if they're not making that conversion, if you're trying to support that 5' deiodinase. Armour has a fixed ratio between T3 and T4, and it's porcine. So the ratio is about 4.1 to 1, which is not human. Human is about 10 to 15, sometimes 20 to 1, T4 to T3. Patients come in requesting Armour, we'll try it, if that's what they want. I also, personally, I take a compounded thyroid, T4 and T3. So I wasn't able, I was started by my reproductive endocrinologist on Synthroid. And, didn't make the conversion, probably because of adrenals. Went to taking Armour, took that for a while. I feel with Armour, because the ratio is more porcine, I see people with suppressed TSHs, low T4 and high T3. Some of them feel okay, some of them don't, with really low T4s and really low TSHs and really high T3s, because that's the ratio, that's porcine, it's not human.
Yeah, and I think there's some things as well that we can kind of tailor or kind of build off of that. And some people really are trying now to provide their patients with T3 only support. What's your thoughts on T3 only support?
I mean, I'm pretty open if that's what T3 is 300% more powerful than T4, right? So T4 does have to be converted from the thyroid into the body, and only a small amount of T3 is made in the thyroid. Most of it is from peripheral conversion, and that is the biologically active, powerful thyroid hormone. I think that might be okay, but what I see is people with higher dose and then suppressed TSH, right? So if they're giving thyroid hormone, just T3 only, because it's 300 times more powerful, if you're giving it and you're not suppressing TSH, then I think that's probably fine. But in my experience, I do have some patients that are just on T3. I mean, but probably the majority of them, you see that they need the T4 supplementation as well.
Yeah, I think when you look at the literature and the research, there's a large percentage of the peripheral cells that prefer to make T3 internally, right? They bring the T4 in. They use some T3 from the blood, but the vast majority of it's converted inside the cell based on cell need. So if cells trying to downregulate metabolism, it may convert T4 to reverse T3. If it's trying to increase metabolism, it'll increase T3. So the cell really likes to have control of that conversion factor, which makes sense because it's what's going on in that cell, that tissue is different what's going on in other cells and other tissues based on with the condition that's going on. The other thing I think we see a big challenge with is that there's definitely some cells that some tissues that have to have T3, right? So you will have, in a low T4 to T3 conversion state, you will definitely rob peripheral cells of T3 to maintain T3 status. That's a biological fight to maintain T3 levels in the blood to support like cardiac tissue. It's critically important. And then the other problem is that the brain doesn't need much thyroid hormone to really, especially the hypothalamus, pituitary, you don't need much thyroid hormone to create that shift and to support those tissues. Whereas the peripheral tissues have a higher level of deiodinase activity. And so it may take more hormone getting to those cells to actually satisfy them. And that's not necessarily being measured by TSH.
Right, absolutely.
So
I think that we see the relationship between the hormones, essentially because of DHEA being produced by the adrenals and that having an effect on the sex hormones aspect of it. But when we look at the adrenals and cortisol being produced, what do you see the relationship between cortisol and thyroid physiology?
Well, it seems like almost 100% of my patients have issues with cortisol, right? I mean, don't all patients, doesn't everybody have stress? It's rarely a patient that doesn't have stress. And so high cortisol affects the thyroid physiology by several ways. One, high cortisol will inhibit release of TSH from the pituitary. So if it does that, you're going to get a falsely low TSH in the sense that, like I talked about, TSH and T4 being both low normal. So that we see that with high cortisol. And also that 5' deiodinase has to have, if it's too high or too low cortisol, it's going to suppress that and favor conversion of reverse T3. Because if you think about it in the fight or flight region, like you said, you want to downregulate metabolism, you can run from a bear. So cortisol abnormalities can affect that 5' deiodinase of the cell so that it's not, you don't convert your T4 to T3. So a lot of times you might see a normal TSH and normal T4, but you're not checking the T3, and that might be low.
Yeah, I think one of the things that we have to be aware with, and I think our listeners have heard us say this probably 100 times, that all the tissues don't regulate the same. So TSH can be normal, it could be low, but other tissues can still be struggling. Brain can be satisfied, hypothalamus can be satisfied, pituitary could be satisfied, but the peripheral tissue is not being satisfied. Because when you're in fight or flight, there's certain systems that the body has to down-regulate because we don't need them for fight or flight response. And other tissues like brain, we need like immediate action for. So we have to support those tissues. So what we see is that we see a down-regulation in some tissues and up-regulation in others, and that skews values. TSH really is only a valid marker of thyroid disease in a homeostatic state. After, in an allostatic state, a chronically stressed state, the thyroid shifts from a set point regulation to really a different regulating system, right? So that the whole idea of TSH, T4 having this kind of positive feedback loop, that goes out the window as soon as we're in a stressed or allostatic state. So that's really, really important to understand. So what do you see as the risk reward for your patients who are coming in with hormone issues from how do you measure that? How do you kind of look at that strategically? I know it's complicated and every patient's different, but if somebody's sitting at home saying, man, I have estrogen dominance, I have hypothyroid stuff. I mean, how do you measure that risk reward of giving them hormone support versus trying to address the underlying factors, but yet still helping them feel better? The short run.
No, that's the reality of it is the area that I'm in is not a well-educated. I don't mean well-educated, but they don't know about lifestyle, functional medicine like California or New York. Okay, we're in the Midwest, right? So a lot of our patients still have that mentality of give me a pill for it, and they're not all coming in. I mean, things are shifting over the last 5 years, and they might come in and say, I'm willing to change my diet, I'm willing to do this. But most of our patients, they want the easy out. So it's very hard for me to navigate, do I give them any thyroid hormone, take a supplement, look at won't pay for a stool test, it's not covered by insurance, so I'm still dealing with a little bit of that. So the question you're asking in the ideal patient, obviously, we would optimize everything up, digestion, stool, we'd optimize their female hormones, to see if those are balanced and optimal before we would give them thyroid hormone. Micronutrients, is their iodine status is okay, how's their selenium, their zinc, that kind of thing. So, but the reality is that sometimes patients, if you give them a little bit of thyroid hormone while you're addressing things, they do feel better, right? Yeah. So I struggle with that a lot.
I think there's a fine line between when a person comes in and they are having symptoms, they want those symptoms gone right then and there. And sometimes if you give them a little bit of symptom reduction and then say, hey, maybe we need to make this long lasting and start working on the functional medicine side. One thing, just kind of spin off what you had just said about the hormone replacement, is also birth control. I often see in my practice, people in their 30s or 40s who have been on birth control for a very long time, they didn't realize that there was a connection between that and their thyroid. When somebody comes into you that maybe is wanting to be put on birth control, you know, do you educate them on the side effects that can go along with that? Because a lot of, you know, traditional doctors don't explain to patients that, you know, this may impact your thyroid secondarily. So how do you handle a situation like that comes into your office?
So I don't do general GYN, so I don't prescribe birth control pills because we're not doing contraception, but I would counsel the patient. And that's one of my pet peeves is people who are done with their family going back on oral contraceptives, or people whose husbands have had a vasectomy and then they start having a regular period and they get put on oral contraceptives. So there's a lot more awareness, you know, especially with Jolene Brighton's book coming out about, you know, Beyond the Pill. So patients are learning about that, but absolutely, I would tell them what the risks of oral contraceptives are, the fact that it's synthetic hormone you're putting in. There was a study that came out, I think it was Lancet 1 or 2 years ago about related to GYN cancer. Yes, it decreases ovarian, but increases cervical and increases breast. Ovarian and uterine were decreased with use of birth control, and the longer you use it. So you've got these people who are like done with their families at 35 and they're taking them for 10, 15 years. So I'm a big proponent to vasectomies or, you know, something else. I mean, literally even an IUD, even though that is a synthetic hormone, it's only one instead of two, you know. So if they have to have something, you know, if they don't have any contraindication to the copper IUD, rather than just doing, you know, permanent contraception rather than temporary.
Mm-hmm.
Hormonal. Non-hormonal is what I would stress.
Absolutely.
And there's two groups there too, right? You have the people who are just like, hey, I don't want the annoyance of it, so I'm going to take birth control. And then I see there's a bigger group of people who have abnormal cycles, really uncomfortable cycles, and they're put on birth control to try and organize their bleeding cycle and manage their symptoms, but they're not told that this really doesn't fix the underlying hormone imbalance, which is creating the problem to begin with. And it sets up a huge problem, especially if those detoxification pathways aren't working. Now you really load into estrogen dominance. Now you really affect those hormone binding globulins. Now you really slow down the production of thyroid hormone, increase the deactivation. I mean, it just becomes this vicious cycle of problems. So I think that's one of the big things I see in my practice is the people that have been on those for, oh gosh, you know, 5, 10, 15, 20 years on birth control because it helped organize their cycle. So it was more effective. And then when they understand how it's starting to impact their physiology and that they really should come off of these things, it's not always a fun situation to come off these things because then, as you probably know, they have that rebound effect when their hormone system is going, whoa, hey, now we can work again. And now they get some of that symptomatology back, right?
Absolutely. Yeah. I mean, we generally try to take people off of birth control pills, you know, and so many of the symptoms go away once they're off of that.
Yeah. And they still may have to fix and address the underlying issue that created their hormone imbalance, their abnormal cycles, their cramps, all those things. They still more than likely are going to need some help to address some of those things, right?
Yeah.
Now, I also see fertility issues as a big one, especially if you are put on birth control right when you get your period and it's abnormal. You know, let's say you're 13, 14, 15 years old, you go on birth control. And then when you get to your mid-20s and you want to start a family, people come off that birth control and their body really, nothing was fixed. You still have a hormonal issue and the body doesn't even know how to cycle appropriately. And then they really struggle for 5, 10 years trying to get pregnant. And the stress of that just adds and these stuff compounds over time.
Absolutely. I mean, because like you said, you're still left with the cause. And then there's a lot of literature that says after birth control pills, those sex hormone binding globulin can be years before it can come down to normal. And so it's probably the same with the other binding protein. We don't routinely check cortisol binding globulin or thyroid binding globulin in someone coming in for female hormone issues. I see these high SHBGs for years after taking oral contraceptives.
Is there any natural ways when you see that those hormones are elevated for an extended period of time that you can kind of help bring those down, or is it just a time factor?
Binding protein?
The binding proteins. Like if you've seen that they've been high sex hormone binding proteins for an extended period of time. Have you learned of any tips or tricks to help lower those, or does it really just take time from not having that demand?
So I've seen some studies about boron, 10 milligrams twice a day being something that can decrease sex hormone binding globulin, but obviously it's, again, what's the cause, right? Is it
Right.
just estrogen dominant? So we're going to work on that, work on the detoxification, that kind of thing. So I don't really give them the boron. I mean, that was something that came up, when at one of our courses, some of the participants said they had good success with that. But usually we're just working on the rest of the systems to try to optimize gut function, optimize adrenals and everything else.
Awesome. So there's a lot more we could probably talk about, but I know we've got some time constraints. So if you were to leave our listeners with some like 3 top tips that if they're struggling with hypothyroid symptoms, hormone imbalances, estrogen dominance, acne, all the kind of fun things that go along with hormone imbalances, what would you be like the 3 kind of broad general tips that you could provide the listeners?
So the biggest tip, number 1, is I think people should know their hormones. I am amazed that people will struggle through and schlep through with these symptoms, and women, we either don't take care of ourselves, or we think it's going to get better, or it gets better, and then it gets worse and it gets better, right? And so what one of my big messages is these women who have estrogen dominance, who are increased risk for uterine and breast cancer, you need to know what your hormones are, right? So that's the biggest thing, is you need to test, and you need to work with someone who knows what kind of testing to do, right? The second message is, if you have an imbalance in your female hormones, does not mean you need to take something. I would say a lot of our patients we don't prescribe hormones to, but we need to know, are you estrogen dominant? We do genetic testing. Do you have detoxification SNPs? We optimize that through diet, lifestyle things. A lot of our patients, we don't prescribe any hormones to, so they don't want to come in and get checked because they don't want to take anything. And then the third thing is, there's a huge difference in the risk profile between oral synthetic hormones and transdermal bioidentical estrogen and, even oral micronized progesterone. There's a big difference between the difference. I mean, if you had a diabetic patient who was getting ready to pass out because they had a low blood sugar, would you give them Splenda? I mean, is that going to raise their blood sugar so they don't pass out? No. So they're not the same thing, right? Sugar and Splenda, just like the same things, progestin and progesterone. So there's a huge misconception with an educational piece, even among, I used to work in a practice of 20 GYNs. I would say probably 18 of them didn't know the difference between synthetic progestin and natural progesterone, and the risk profile and the receptor affinity and the actions. So that's the third thing, really. So first, know your hormones. Second, you don't just knowing your hormones doesn't mean you have to take hormones, but there's other things that you can do to modulate your hormones. And the third thing is, make sure that you know about the difference between the risks and the benefits. And I'm just someone who, you should never take oral estrogen. You should not take synthetic hormones. Birth control pills are for birth control. You don't need contraception. It's not a good way to cycle control.
Well, great advice. And I think one of those things to follow up with is definitely if you're struggling with those issues, there's going to be a totally different perception of how to address these things, whether you're seeing an allopathic physician or an integrative or functional medicine practitioner. And it's not, I wouldn't say everybody's trying to do the best to help you, but they're working within their paradigm of how to address things. And I think in that allopathic model, it's about just trying to manage symptoms and numbers versus really trying to optimize health. And I think that's probably the big difference that I would say is the number 4 to your 3 is be observant or be educated about who you're going to see. Because if you don't want birth control type medication or synthetic medications, and you're going to see a traditional endocrinologist, that's more than likely what you're going to get. And if your testing is going to be limited, so you can't ask them to do something that they typically don't do. And if you're looking for a more natural approach, then you want to seek out somebody who's in functional or integrative medicine or practices along those ideas, because they're going to probably provide you what you're looking for. And you're not going to be butting your head against the wall saying, why won't they listen to me? Why won't they do what I'm trying to get done? The real answer is you're asking the wrong person for the wrong advice. Would you agree with that?
Absolutely. Yeah. And even, like I said, even gynecologists, like we're not taught this. So we don't know this unless you seek out the training. And I would even piggyback on that. Even a functional medicine provider, unless they have training in hormone therapy, they still may not. I don't know why it's kind of a standalone thing. I mean, when you learn functional medicine, a lot of people learn about adrenals, gut, thyroid, that kind of thing. But there's also functional medicine providers that maybe they specialize in infectious disease and Lyme, but they might not know anything about hormones. So really, even knowing, is this something in your wheelhouse? Is this your niche? Something that you prescribe? Because I've also seen patients from other integrative practitioners. I'm just half an hour south from Cleveland Clinic, functional medicine, and there's not anybody that has a specialty like me in hormones.
Yeah, there's not standardized education within functional medicine or integrative medicine either. And there's still people that kind of deviate. There's just too much here to learn to know it all. And so, we have to be generalists in integrative and functional medicine to some degree, but there's definitely things that we can really get more focused on. But it's nearly impossible to know it all. So definitely when there is things that get deep into the hormone thing or the thyroid things, there's a generalist approach. And I think you're going to find that in our practice, integrative or functional medicine, you're going to find the same thing you find in allopathic medicine as well. Is there's a generalist approach. And if you try it and it works, fantastic. But if it's not working, then you want to find somebody like yourself who really does dig deeper into a specific niche and can help the other stuff as well, but really has a concentrated niche in hormone physiology. I think that's really, really important. So I'm glad you shared that as well.
Yeah, I would agree. Like I wouldn't see a patient with Lyme. I don't know much about infection, right? So it's not my wheelhouse.
Yeah, I think that's good. I think we as integrative practitioners sometimes have to be willing to say, hey, this isn't the thing I'm best at. I think you should go see Dr. So-and-so because that's really what the focus is. And I know I spend a lot of time looking at files from people who've been to multiple integrative practitioners, and you go, yeah, they're kind of following like kind of a cookie cutter, do the gut program, the detox program, then you do the adrenal program, and then you do the hormone program, and you should be good because I've gone through all the things I learned in those 4 modules of my training. And I think and you correct me if I'm wrong, but the real beauty of what we're trying to do here is not learn a system. We're trying to like a system, a protocol of treatment. What we're trying to do is understand each individual is an individual, and how they got to their disease and their dysfunction is different for everybody. They may have the same diagnosis, but how they got there is different. So how we need to help them is going to be different as well. Would you agree with that?
You have to personalize your therapies, and that's why I've had a problem just putting I don't have a program because I just can't be pinned down to the same thing for everybody. It's got to be personalized and individualized.
Right. And so I think that's one of the things you see when you're talking about how do you, I kind of gave you threw a question out there, like how do you address these people? And I think you did a good job of getting to that answer. Instead of giving like, well, everybody kind of follows this protocol or program, it's so individualized. And I think sometimes our patients have that problem. Hey, my friend did the patch and it worked, and it's not working for me. So you must not be you're not the right doctor, right? And the reality is we're not trying to fix you with a protocol. We're trying to understand your physiology and the best way to support it, not make it work, but help support it to work appropriately.
Yeah, I think regardless of whether you're talking about hormones or thyroid or a type of diet that you follow or a skincare line, every person is different, and their body's going to respond to that particular program or technique or product totally differently because we're all individuals and we all have different physiology that's going on and different pathways that are broken. And so you have to look at the body as a whole and just ask the questions of what is causing this and why is this causing it, not just force a thought process on a patient. And I see that frequently where they've come in and they've done those exact same things, we'll till your gut and then we're going to detox you and then you should be great. But if you don't take a step outside and break your mold, sometimes we can be, not treating the patient as appropriately as we could.
Absolutely. So Dr. Tara, can you give us give our listeners an idea of where they can find you? We're going to put all the information in the show notes or in the podcast notes, but where can they find you if they need some more help from you?
So my practice is called Revitalize. RevitalizeMed.com is my website. Facebook, I'm always trying to put out free content, videos, patients on Facebook and Instagram. Again, just trying to get that education out there.
And are you teaching practitioners as well? Because I know we have practitioners that listen as well.
Yes, so I teach a course through LP3 Network, which is a company out of Canada, and we teach a 2-day, like a kind of basic hormone course, which is thyroid, adrenal, menopause, andropause, if you believe in that. And then there's a 1-day kind of like a advanced course that deals with gut, food allergies, neurotransmitters, anxiety, micronutrient testing. And we teach in Canada, the US, Australia, Philippines, Malaysia, we've been to. So it's a 2-day course. So we started out teaching mostly to pharmacists. Then we got accredited for naturopaths. Now we're accredited for MDs, DOs. So we got CME accreditation this year. So that's awesome.
Awesome. So I thank you so much for coming on. We'll have to get you on again. There was a lot of great information. And next time, instead of more of a general view, maybe we can dig deep into one specific aspect and get a little bit more information. So thanks so much for coming on. We appreciate it. Stay dry and stay safe over there in Ohio, okay?
Yeah, thank you for the opportunity. And I appreciate that you guys are doing this just to kind of educate people, because that's my mission too. And so I appreciate you guys just trying to get the word out to educate patients too, because you know, they're not told by their practitioners to seek this kind of care. So by empowering patients to advocate for themselves and letting them know there's other ways to treat them, your approach, that's great too.
Absolutely.
Awesome.
All right, Dr. Erica, I will see you again. Dr. Tara, thank you so much for coming on, and we look forward to having you on sometime in the future. All right?
Thanks.
All right, take care, everybody.
Thank you.